one of the luckiest presenters, because what we're going to talk about today, just to get things started, is an overview. Even though I know you just had a logistic overview, this presentation is introducing concepts that hopefully you will keep in the back of your mind as you go through the entire course. My name is Rosalind Platzker, and my pronouns are she and her. I'm an assistant professor at the UCSF Department for Epidemiology and Biostatistics. And so by the end of this lecture, you will be able to identify the settings where COVID-19 outbreaks are likely to occur. And many of you are probably already aware of some of these. Then you'll be able to describe the goals of outbreak management, also something I have a feeling you're already familiar with, but we'll go over it in a systematic way. Then I will teach the 5 steps in our systematic framework for outbreak management. And if there is anything that you pay attention to in the next 20 minutes, I want you to pay attention to that part. After that, we'll talk about how different response teams are structured. I know that this can vary from county to county, and LA is a particularly large county with a high disease burden right now, and so different settings might have different structures, so we'll go over that. And then finally, I want to introduce a concept about outbreaks in general that is called open and contained. And so we'll go through what is an open setting, what is a contained setting, what does that mean, and how does that guide your management? So to get things started, I wanted to introduce a few settings that you are likely very familiar with already, and some numbers that are disturbing. First is about skilled nursing facilities. So over 284,000 COVID-19 deaths have occurred in the United States, and 40% of them were either residents or staff of skilled nursing and long-term care facilities, and this totals some 100,000 people. I know that in LA, SNF management is a high priority, and that this is also true across the country. So I wanted to bring that up first and foremost, and also show that this is something that has been steadily increasing since the beginning. So back in April, we had 30 states that were reporting cases from long-term care facilities and SNFs, and specifically reporting deaths. That was back in April. And by November last month, all 50 states reported deaths. And by last month, over 100,000 deaths occurred. So this is a huge priority for your work. The next thing that I wanted to talk about briefly was people in incarceration settings. So the United States, one of the reasons this is important is because the United States has the highest per capita incarceration rate in the world, which is not something that I am proud of or that we should be proud of, and that these individuals are in a congregate setting and therefore are at high risk of COVID-19 exposure. So this data is from the COVID Prison Project, and the most recent data I could get was as of November 27th, so right around Thanksgiving. At that point, over 200,000 cases had been documented among people who were incarcerated in prisons. And keep in mind, that does not include juvenile detention centers, that does not include jails. Also, almost 1,500 deaths occurred among that population. And then among staff, almost 50,000 people, just over 47,000 had been diagnosed with COVID-19. And of those, 74 had died. So this is another population that you'll likely be working with, not just in prisons, but jails as well. And so I wanted to address that. And finally, with workplaces, this is as of yesterday. And I'm talking about specifically food processing and meatpacking workers, but I want you to keep in mind that this issue applies to multiple workplace settings. This is just a good example. So as of yesterday, 49,776 meatpacking workers, which involved more than 550 plants, had tested positive for COVID-19. So very close to 50,000. and more than 250 of them have died. One of the reasons that this is especially important from a health equity lens is that about 80% of meat packers in the United States are racial or ethnic minority. So this is also a huge, huge health equity issue. In addition to that, in food processing plants, 13,866 people were infected across 680 plants. And then among 268 farms and production facilities, over 11,000 people have been infected. So these are just a couple of highlights of different settings where you might work as an outbreak manager, because these settings are outbreaks. And so, Ali, if you're able, oh, sorry, we're responding in the chat. So, we have a Zoom poll also coming up, but I wanted to ask if you could respond and just chime in and say what these settings have in common, and why are outbreaks occurring in these settings in particular. And so you can go ahead and respond in the chat. And also, Andrew, if you're able to, could you read some of the responses, because I have trouble reading them while I present. Thank you.
They're crowded indoor facilities. There's lots of close contact, close proximity, high density of people, close quarters with low hygienic purposes, no social distancing, inconsistent use of PPE, close proximity, high density, close proximity, together.
Okay, so we have a unanimous agreement that this is indoor settings, that there is density, there's close proximity, and that's exactly right. Outbreaks occur where people congregate, and so that is especially true indoors. And so, you know, that happens in skilled nursing homes, it happens in correctional facilities, it also happens in schools and workplaces and shelters and single room occupancies, as well as government receptions in this administration. But you guys hit the nail on the head. Now we have a Zoom poll. So, Ali, when you have a chance, could you please launch our first Zoom poll of this presentation? What is the most common way that COVID-19 is spread? Airborne transmission by aerosolized particles? Is it mostly by droplets? Is it via contact with contaminated surfaces? So now that, you know, when we have everybody in an indoor environment and they are close together, what is the actual mechanism that the virus is being transmitted from one person to another? Okay, so I'll give it one more moment. Still a few people voting, counting votes. Okay, all right, I think we can end our poll. So, so the vast majority of you got it, that this is mostly spread by droplets. And the droplets are projected when a person who's infected coughs, sneezes, or talks. So let's go on to the next slide. So like I said, this is through droplets. It can happen through contaminated surfaces. I hesitate to say that as a hard and fast rule, but it's possible. And so that's why it's important to make sure that surfaces are sanitized. You see this in public, you see this at stores, you see this in health facilities, that there is a very, very rigorous adherence to wiping down the surface every time. You know, so hopefully you see that in your data. With the droplet, one thing I want to mention about that is that typically droplets are thought to project about 3 feet. So if you cough or if you sneeze, usually the droplets that have the virus in them are about a 3-foot diameter in front of the person, at which point they drop to the ground. And so one of the ways that we got to this 6-foot distance is basically doubling that. So you have 3 feet from one person, 3 feet from another person, you put those together, you get 6 feet. Sometimes there's some evidence of airborne or aerosolized transmission. Ventilation definitely contributes to that. So if you have a poorly ventilated space, then you have a higher transmissibility. And there's some thinking that that might have to do with aerosolized transmission, but mainly things are spread through droplets. All right, so why is outbreak management so important? I am definitely preaching to the choir right now, but just to say it out loud, during an outbreak, there is a high risk for transmission in congregate settings, and we know that outbreaks typically occur in congregate settings. When there is high risk for transmission, there is subsequent high risk of complications and death, which occurs especially among vulnerable populations. And so by managing an outbreak, you have the potential to stop transmission and therefore save lives and therefore enable greater health equity. Okay, so that is the main reason why outbreak management is so important. Now, I realize we haven't really said what an outbreak is yet. So this is a very basic outbreak, a very basic definition of an outbreak, excuse me. So essentially, an outbreak is when you get more cases than you would expect. And the key is that that happens at a specific place and a specific time. And we'll talk about that more when we talk about defining the scope today. But this is an example of an outbreak as a graph. And so here you can see that this has to do with a time period where you have, let's call it week 1 and going all the way up to week 20. So the x-axis is time and the y-axis is the number of cases, and this is for a specific place. So you can see that in general, it ranges from about 1 to 5. And then at around week 12, we see that it's a little bit more than 5, and it actually goes up to 10. And then by week 15, it has jumped all the way up to 30. So this is a very unexpected uptick, and this would be considered an outbreak. And then you can see that it declines and it goes back to baseline. And this is what we would want to see to confirm that the outbreak is over. And hopefully this decline is due to outbreak management. So in theory for COVID-19, the expected number of cases would be at 0. You know, we wouldn't be at 1 to 5. We are aiming for the best, for 0. In reality, different settings and different jurisdictions are going to set different thresholds to identify an outbreak. So as you manage outbreaks, in order to determine if an outbreak is actually occurring versus if this is a single case that wouldn't warrant further investigation yet, that's something you would need to establish with the setting that you're working with or with your colleagues at the health department. So it's not quite hard and fast yet. In terms of the goals of outbreak management, we talked about this a little bit in the previous slides, but you do want to reduce transmission. And in doing so, you would reduce illness, complications, and death, like I said. In addition to that, it's an opportunity to evaluate the prevention strategies that were already in place. By now, every setting should have some kind of COVID-19 plan that is their way of preventing an outbreak in the first place. And so this is an opportunity for you to look at that plan and figure out where there are gaps. And then once the outbreak's over, you can inform future prevention strategies based on that. So there's definitely an evaluation process. And then in addition to that, another goal of outbreak management is to address public concern, because clearly outbreaks can generate attention from the public and from the media. And so part of your job as an outbreak manager is going to be to address that. All right. Now, is everyone awake?
Yes.
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 Okay, this is the part I said, if you learn anything today, please learn this framework. It will haunt you if you don't. So this is how to prevent an outbreak, or excuse me, how to manage an outbreak. So the first thing you want to do is prevent it in the first place, right? So the first step in outbreak management is prevention. And this is where you think about mitigation plans, you think about infection prevention and control that's already existing, and you also think about communication with local health departments. If there is a need for something like PPE, is the SNF or the workplace or the school able to communicate that to the local health department or not? So this is what you do to prevent the outbreak in the first place. So P is for prevention. Please, everybody, say that in your head. Next, you identify cases. Then you link to a setting, and then you set the threshold. So this is identifying the outbreak. I know it says just identify here, but you want to figure out if there's an outbreak or not. And the way that that happens is you have cases, and and then you notice this common thread that they're all associated with a workplace, or they're all associated with with an incarceration setting or a SNF. And then once you figure out which cases are associated with the setting, you can set a threshold and say, yes, this is an outbreak. After that, you want to define the whole scope of the outbreak. So that really is, if you think about an outbreak, think about the boundaries of the outbreak, both spatially and in time. So how far back do you want to look, and who is involved, and what is the setting? So if it's a school, does it include teachers? Does it include staff? Does it include parents? Does it include students in all the grades or just one grade? You really need to define it very carefully. Once you've defined it and you say it includes this population, this place, this time, then that's where you do your surveillance testing. That's where you check everybody and you monitor them in terms of if they have an infection or not, if they've isolated, if they've quarantined, et cetera. So that really is the case finding and the data collection. And that all falls within defining the scope. So we have prevention, identify, scope. Got it? All right. Then once you have defined the scope of your outbreak and you have found your cases and you have started to collect data on them via testing, as well as working with your liaison, then you control the outbreak. And so this is what people normally think of when they think about managing an outbreak, is controlling it. And this is where you have your routine testing, you trace contacts, you isolate the people who are positive, you enforce prevention measures, you really have the dogged iterative checking on masks and hand rub and enforcing closures and restrictions, right? So this is what people think about as control, because this is when the outbreak starts to go down, ideally. So after you define the scope, you can control it, but you can't control it until you define the scope. And finally, you monitor things. So you keep an eye on it. This is not simply putting something in place and then letting it go. You need to have a consistent communication with the setting. You need to have ongoing reporting as well as follow-up, and you need to, repeatedly assess control measures. So make sure that people are using PPE, make sure people are using alcohol-based hand rub when appropriate, make sure that the social distancing is actually happening. And this is really an iterative process that can be tedious, but is so necessary. And so monitoring, there was one learner who offered an acronym for this, which is PICE, not to be confused with Pisces. It's like the single Pisces, prevention, identify, scope, control, and then she suggested evaluation instead of monitor. So I like that acronym. Please use it or come up with your own, and you can share it with your colleagues. All right, so we've got a couple minutes left. I want to talk about response teams. So this is an example that the CDC has about how teams can be structured. In this response, you have an epidemiologist, a laboratory support specialist, an infection prevention and control specialist, a case management specialist who works with specific cases on things like isolation and quarantine. Sometimes these people work very closely together, actually, especially if it's a SNF or correctional facility, because you need to understand the isolation quarantine alongside what other prevention measures are happening. It isn't just isolating someone at home outside of the setting. Then you have the social mobilization specialist, which is kind of an interesting role where it has to do with basically helping people who are in the setting understand the behavior modifications that need to happen. And then you have your risk communication specialist, which works closely with this person and has to do with writing up the guidance that you would put on the walls, signage, letters to family if it's an inpatient setting, things like that. This is another example. It's an incident command system. This typically happens in larger outbreaks. So, you know, for example, at the San Quentin outbreak, they had an incident command system. At counties, they have incident command systems. At CDPH, they use an incident command system. And basically, this is a larger operation where you have your incident commander supported by a liaison officer, a public information officer that has a relationship to the press, and a safety officer. And then underneath the incident commander, you have a section for operations, a section for planning, a section for the logistics, and a section that has to do with the finance and administration. So this is another example that you might come across if you are doing a larger outbreak. All right, and finally, I want to leave you, I know we have like -1 minute, but I want to leave you with a concept about open and contained settings. So an open outbreak setting is when all members of a community in which the disease transmission is occurring are also involved in outside groups. And the reason that this is important is because they can introduce a new infection from an outside source, and anyone who becomes infected in the setting can then expose their outside group. So this is an example. We have schools, workplaces, encampments, SROs, and you can see that there's this setting, but then there also are these outside settings that can be impacted as well. I'm going to skip the Zoom polls because we're short on time, and I'll just tell you the answer, which is all of the above, that teachers, students, custodial, cafeteria, security staff, all of them can contribute to infections leaving or entering a school-based setting. A contained outbreak setting is when most members do not leave the setting where disease transmission is occurring. So some people can enter and exit, but the majority of people are contained. And so that would be a nursing home or a correctional facility. And here you would have staff, visitors, etc. And again, I'll skip the Zoom poll. This one was actually a trick question, so you guys are lucky that I'm skipping it. But basically, all of these people can contribute to COVID-19 entering or leaving a skilled nursing facility. So a patient who's discharged from a hospital, a healthcare provider, a visitor, and people like drivers who are transporting residents. Now, the thing I want to leave you with is that this open and contained setting is really a spectrum. Nothing is 100% open or contained. And so when you're assessing this, you want to think about how contained is the setting. And when you think about how contained the setting is, then you can think about things like, how do I stop transmission within the setting? So you think about the internal behavior. But you also can think about how to prevent infections from entering the setting, so introduction of a new infection, and also prevent infections from leaving the setting, which is also complicated, because if you want to contain an outbreak, you need to prevent the infections from also leaving. All right, so now we are officially done. Hopefully you are comfortable with identifying settings where outbreaks occur, as well as understanding the goals of outbreak management. I hope that you have committed the 5 steps, PICE, P-I-S-C-E, to memory. And also, I gave you a little taste of team structures. And as you go through this course, please just keep in the back of your mind this idea of open and contained settings. All right, and with that, I'm going to stop sharing my